Good afternoon, everyone. Thanks for joining us today for this ADCES webinar that will help you understand the new COVID-19 telehealth regulations just released by CMS and how you can get up to speed. A few housekeeping notes. We will be having a Q&A session at the end of the presentation, so if you would like to ask a question, you can type it into the questions box on your screen. We'll answer as many questions as we can at that time. In the box at the bottom of your screen, you can download a PDF copy of today's slides. We are recording this webinar, and the recording will be posted by this Thursday, March 26th, on our COVID-19 resource page, which is accessible by going to our homepage at diabeteseducator.org. We'll also have a direct link to that page for you at the end of this webinar. With us today is Chris Keelan, a registered dietitian and certified diabetes care and education specialist at the Billings Clinic in Miles City, Montana. So Chris, I will turn it over to you.
Thank you. Thank you all for joining us today for the ADCES program presentation, Understand the New COVID-19 Telehealth Regulations, just released by CMS, and how you can get up to speed fast. There you go. I read it all for you. And my name is Chris Keelan. I've been practicing in Montana for a number of years and coordinate and run a program out of a primary care office at the Billings Clinic in Miles City. I've been doing this telehealth for many years, and my historical attribute has been to offer it to facilities not related to the one I work in, but offering telehealth to remote sites out in the lands of Montana, hundreds of miles away from me. I'm going to start off with a slide that is simply for you who are going to get the slide PDF, that messy slide of the definition of what is telehealth. So I'm initially going to start today by giving you the definition of what CMS has given to us when we want to get that information providing DSMES to our patients. What is telehealth in their words? So the U.S. Department of Health and Services has given us a big, robust definition about the use of electronic information, the telecommunication, the real-time audio, video. This is now including things such as remote monitoring that we might be using, but for their purposes, they've given us a big, robust piece of information that can help us to define some of the things we might use and embed into our practices. And as I said, I do want to give you the traditional language that CMS has given to us that makes us know to comply with their requirements to offer telehealth DSMES, meeting the needs that they define as HIPAA compliant, interactive audio and visual telecommunication that permits a real-time communication and visualization. Sometimes I say to my patients, we're going to be talking to the TV and we'll be able to talk back to each other as I explain to them what telehealth is going to be, but we do need to make sure that we adhere to some of the security definitions and we adhere to the HIPAA compliance components as well. The thing about our ability to provide telehealth per the CMS guidelines is the reimbursement, same as in-person face-to-face. So if someone is in your office and you're doing some of those Medicare or those CMS billings, the reimbursement for telehealth has always traditionally been same as in-person, face-to-face. High level of satisfaction for the patient and the provider. The network that I matriculate with, the Eastern Montana Telemedicine Network, oh, I backed that up. Don't know how I did that. The network I communicate with does some research that helps us to understand what we're doing in terms of saving patients time and money, and we've seen at least $200 to $300 savings per patient per interaction with DSMES, saving them the ability to not have to travel the hundreds of miles to our sites, but also to give them a big cost effectiveness. They're very happy. And I'm enjoying it a lot too. I've been doing it for a number of years and have found a way to make it a real part of my program. So CMS, again, does give us definitions that we have to adhere to. And initially, one of them is where the patient is originating, where the patient is in the service line is the origination site. So where that person is a medical facility that is designated as rural by the healthcare professional shortage area, as well as a CMS qualified rural county. In Montana, that includes all but 2 of our 56 counties, so we know that we're identifying patients in our service area, definitely meeting the needs in rural. And it also defines a location where the patient has to be in the traditional model that says they're in a provider office, a critical access facility, and there's a few others, nursing facility, renal dialysis center, community mental health center. Where the provider is, the person rendering the service, is a remote location, and that is a facility where the patient or the provider needs to be rendering it. And here are some of the critical rules also that CMS defines as approved billing providers are doctors, DOs and MDs, PAs, nurse practitioners, certified nursing specialists, certified nurse midwife, a clinical psychologist, social worker, and the registered dietitian. So in a program that's offering DSMES, the billing provider must be the provider rendering DSMES to the patient. Right now, these particular rules do not allow a registered nurse or a pharmacist to render the services. That's a CMS rule. None of us really like that rule, and we're hoping that that's something that could be changed. But right now, in most DSMES services, mine included, I'm a registered dietitian. I'm rendering, and I'm able to bill. So traditional telehealth rules for DSMES do support that there's a location where the provider and the patient are. We have to realize that that's an important part of those rules. We also have to know that there's that rendering piece that's a real important part of the rule. And then another additional part of the traditional rules for telehealth DSMES per CMS is that there's a protection of HPI with some security end-to-end encryption. The networks have to be HIPAA compliant, and they have to meet those security needs. Most folks are using networks that have a business associates agreement so that they can have all of those components in place. But now let's talk about what everyone's here to talk about today, or to listen to, the COVID-19 urgency that we're all facing, and how we take that knowledge about traditional CMS, telehealth rendering and offering services, what it means now. Because of the March 6, 2020 Coronavirus Preparedness and Response Supplemental Appropriations Act, the 1135 waiver allows for some removal of limitations that had been part of that traditional package. The biggest one is the patient location no longer has to be required to be rural or to be required to be in any specific site. And what that really means to all of us is we can reach the patient in their home. It's kind of what the patients have been asking us all along, we might reflect on, but that is one of our biggest barriers removed with this 1135 waiver. So we also know that patients could be in another facility, they could be in another place, but they don't have to be rural, they don't have to be in a specific place. It means a big impact for folks in urban areas, because that provider doesn't have to have a restriction of rural. You could be seeing them in the same town. So the services that are normally furnished in a DSMES program, and we can include MNT codes as well in this, but today's topic is about DSMES, the GO108, GO109 codes that you'd be providing in your hospital or critical access hospital outpatient settings. You would be using those same exact codes. What we know right now with the 1135 waiver is what we're doing under the CMS guidelines. We also know the waiver is encouraging states to offer Medicaid beneficiaries the same opportunity, as well as offering some commercial insurance parity. But today's topic is about what we know the rule change per CMS guidelines. I want to take a moment and address some things that we've kind of been pondering about, because this is specifically in italicized print because these are pending changes that could be still coming. We haven't received word that approval for the rural health clinics and federally qualified health centers are going to be approved. There's some legislation actually saying that this could be moving forward. We haven't seen that legislation finalized. Additionally, CMS has been asked to allow registered nurses and pharmacists to be providers of telehealth. In both of these cases, we don't know the answer yet, but today is the day we're presenting this. It could be a different world tomorrow. I think as everyone realizes, life changes, maybe not day by day, but moment by moment right now. So I want to talk about tech platforms. We just realized with some of the earlier slides that we're saying we can reach our patients right in their homes. So what is that going to mean as far as reaching the patients on a platform? The traditional telehealth products really had a robustness that we had to adhere to as far as meeting HIPAA compliance, having a business associates agreement. We are now actually able to pursue products that could be more familiar to the public. We might even, on this slide, it's suggesting we could use Skype, we could WebEx, we could Zoom. Those are products that people are familiar and might even open up their smartphone and say, hey, I have that. But we do know that it's really important to make an effort to adhere to some of our compliance standards regarding protecting the PHI. We really want to be able to try to look for products that do support some HIPAA compliance, that might have a business associates agreement so that we can be assuring that our patients have that opportunity. An important part of the 1135 waiver also is that CMS is not going to be auditing for any variations or any potential problems with adhering to the violations of HIPAA. So if we have an instance of setting up in good faith a connection with our patients and there is something violating HIPAA or a practice that could potentially be hacked, CMS is specifically saying they will not audit, which probably means that they're not going to hand down any infraction kind of fines or problems, but it is important that we think I still do want to adhere to the best guidelines that I could. So we don't want to have any hacking exposure, but we still should try to recognize that all of these platforms made available should be entered into with the best faith. So what has been defined by Health and Human Services is use of products that are non-public facing communication. So they would be used for intention of just the parties that we're intending to connect with only. So we could potentially use a product that sends an email invitation for someone to open up that meeting room and get on board with the party at hand. Not so different than what you did today by logging into this webinar. It could be something in that type of communication. Some of these might be more suitable for individual, just one-on-one visits. There's ability for some of these products to allow for entering a room to potentially be a group setting. So some of the words that folks would recognize: Apple FaceTime, Facebook Messenger, video chat, Google Hangouts, WhatsApp, and Skype, as well as Zoom, are products that are specifically mentioned in some of the CMS literature saying, here's what we're going to allow folks to go ahead and get into. Some of these products also allow some texting applications that do support an end-to-end encryption. So we know that some of these products could be useful to folks who are trying to get on board with this right away and get the show on the road. We're going to show you these next few slides are going to show you that there are some telehealth platforms with HIPAA and business associates agreement readiness for providers. Some of these terms would be, some of these products would be terms that you've already been used to seeing. A few things look familiar to me, and especially with regards to some of the things that I might have used just connecting with peers or something that you might have done yourself. ADCDS does not endorse any of these sites in particular, and nor do we say these are complete lists of products out there, but they do provide examples of readiness to support healthcare providers and also ability to oftentimes meet HIPAA compliance. I'm not sure why that wants to go backwards again. So as we explore the telehealth options, these are certainly some of the tools that we could be using. In my facility, we're using a Skype for Business, and it allows for, we've already been using that with interprofessional relationships within the facility, and so now being able to utilize it with our patients, we know that it does have some HIPAA protection and some security in place. I have some peers who are using, I think it's Zoom for Healthcare, and some of these indicate that we're needing to make sure we have an adequate number of licenses to use the tool. So in some facilities, There's a little shuffling of who goes first to the gate of getting access to some of these products so we can move forward with meeting with our patients over telehealth. And we as providers of DSMES know that we're not the only ones trying to get to our patients, so we're seeing a lot of engagements on how we can pursue this with primary care providers in mind as well. This list indicates some of the electronic health record vendors that typically have products for a fee. And in this environment of COVID-19, this is a listing, again, not complete of everything out there. In fact, I did look at Video, which is the product that I also use in the traditional model to my healthcare facilities. They're also looking at, looks like a short time frame of some free access or free trials. So these particular products on this list could be investigated for use in for customers to be, they could purchase them. It looks like down the road, but they're offering free trials or some free access. Some of them have time frames on them. I think there's a 90-day within the list here of Dr. Cromo, my apologies, pronounce, but some of these would have opportunity to investigate how you could engage in there. And these do have HIPAA and Business Associates Agreement. So it needs to be made very clear that there are not acceptable platforms also. And hopefully those of us in healthcare would probably be pretty well familiar with the fact that Facebook Live is something more conducive to filming your kid's concert versus opening up a chat for everybody. But this is something that's very important, that public-facing remote communication products, TikTok, Facebook Live, Twitch, or a chat room like Switch. I'm not all that familiar with all of these, and in the words of my 18-year-old mom, it's not for you to know about. So I would say that these are things that definitely allow for some public-facing, meaning there's individuals in the public and in the community that could actually see what's happening within your meeting or your visits with your patients. The website on here is a place where you can look for some of these frequently asked questions from Health and Human Services. It does provide all the details of and specifically mentions a lot of these websites and platforms that you can go to for more information and help. So going through all of that detail of what's good and what's not and how we can get started and what's important to know about, I think it's really important in my perspective as I approach this is what we do with our DSMES program structure. So some of the important ways that we have to think about moving forward our connection with our patients. We're now looking at a different way of not necessarily seeing them across the table, but we're seeing them through an electronic connection. We still have to recognize that there's some important rules in place. You need to be offering your DSMES through an ADCES accredited program or an ADA recognized program. That was in place traditionally and it is still required. So you still need to be offering your program through one of those status structures. It is true now that we still have the rendering provider considerations on those lists that was embedded in the traditional information. So we still know that we aren't able to modify from that. It still has to be the same rendering provider rules apply. We also have to think about platforms in the facility. I was assuming last week about this time that we were going to go with our video platform, but that did not easily matriculate into a patient's home. Skype for Business did, and so we had to kind of shift gears and go a totally different direction. What this created is a whole new work action plan for individuals within my facility. In my program, I am in a very small rural healthcare facility, so I do kind of the whole shebang of getting my patients scheduled, connecting, doing it all. So in some programs, there's going to be a lot of changes amongst how scheduling is done. So we have to consider a lot of those different opportunities and being pretty nimble and ready to change. Like I mentioned, we are using Skype for Business at the Billings Clinic, and we know it's HIPAA compliant. Some of my peers in Montana Deb Bjornseth at Benefice Great Falls said that she was making a real easy transition to her DPP classes last week with a Zoom app and was able to get people connected through that app for their classes. But again, back to considerations for how many licenses a facility might have, how we get the platforms going. We need to, in our facility, do a web-based invite with an email to our patients. So there's a lot of changes in the information we gather from our patients. Again, I want to talk about program consistencies for DSMES, and we need to remember that when we engage in this service that we are delivering in 30-minute increments, same as in person. So we're delivering our same structure of our program as though we were in office. Our telehealth delivery is the same. It's very important to remember, as we can, in my head, there's the ADA recognized program cycle of content delivery. So I need to make sure I have assessed my patients' learning needs and planned an education plan based on that assessment. So because of that, I have to also remember that I have to use the same assessment tools. My tool is, I could potentially do a PDF email to my patients, but I have to be very careful with that because of our possible cybersecurity risks. So sometimes I might even actually be doing it over the phone using my assessment tool to gather plan for the education and the content delivery. Programs are curriculum-based, so we need to adhere to our curriculum base and teach to that same model. At Billings Clinic, we've gathered as a group of educators and made sure that our education materials speak to our curriculum, but also give us some flexibility with what we might use for our patients. What served me very well in my rural facilities and my traditional telehealth model is to use materials from industry partners, and that's made a really nice transition for me to be able to get materials sent to a facility or being able to ship materials to a facility, and I can actually have folks use those in different ways, but those materials could also be done the same for if I were to use those tools for my patients via telehealth, because some of them could be accessed web-based. So if I have a favorite Merck or Lilly or Novo teaching tool, a lot of those are available online, and I can direct my patients there. And I also need to make sure I have tools and my camera set up and things in place in my office, so if I do need to do an insulin start or a glucometer training, I can get that delivered based on how the camera is capturing that. The billing and coding is the same as in person, GO 108 and GO 109. That is no different in telehealth. There is a code for the place of service that Medicare says it needs to be reflected in the billing. The place of service code 02 telehealth is used. And at my facility, this has been we've kicked this ball around for a couple days, the use of a CPT modifier GT. I've long used that to indicate that the service was offered via telehealth. I have had that confirmed with other peers in my billing department. There is the Medicare place of service code 02 telehealth that seems to be in the literature right now as what's sufficient. However, at my facility, I do use a CPT modifier GT. I want to talk about how to envision setting up your program for telehealth. This is a brand new frontier for you, how you would actually go about seeing a patient get embedded and getting engaged and seeing them through the process. It's important that we look at our patient appropriateness. And so those are things that I'm doing right now with my scheduling of my patients. I can tell based on a lot of things that I know about some of my patients whether they're at an appropriate level or not. If I'm getting new referrals, I have to do this based on a phone call. So right now what we're sort of triaging is asking our patients if they have an email address. That's important for us because that's how we connect with our patients and send them an invite for the education meet. I ask them if they have access to a smartphone, computer, or tablet, and especially when I'm asking them that if they have a camera and audio capture speakers. So those are very important because it needs to be that audio-visual in real time to be a telehealth visit. I need to know about any visual or hearing barriers that my patients might have, And then I have to find out if my patients want to have that format of telehealth, if that's something that they're agreeable to. When we talk about getting our planning for what our staff is going to be doing, we know that there's going to be more patient contact and prep time. It's a lot different than someone calling in and saying, I got a schedule, putting them on, and they're going to walk in. So in our facility, we've all been communicating and been very, really supporting how kind and we don't want to say persuasive, but how we can approach our patients so that they can understand what our transition is doing. We need to get their permission, but we also need to advise our patients what this is going to be like, how it's going to be set up. So we might need to do some advanced training, and we're sort of allocating a lot of phone time for that right now because we know we need to be explaining the process, asking the questions, and being able to support them so that they're ready. In the case of a lot of the nurses who are working with our primary care doctors, they're doing a lot of that so their provider's ready to slide right in. In my case, I'm doing a lot of it, and especially being aware of being kind and considerate of our patients. I don't want to overburden them with any of my needs because I'm calling them about tech, and they want to know exactly what it is that they're going to be getting out of it. I did this with a very nice lady this morning, and when I was rolling down my list of, do you have email, do you have a computer, does it have speakers, what's your phone like? She has a flip phone and she doesn't think she has a camera, and I was rolling along with my asks, and finally we get to the end and she just said, Chris, can we just do this on the phone like we're doing right now? To her, I was fortunate that I had already had a session with her, but to her she just wanted to engage in DSMES, really. She had kind of identified some education needs, and she just wanted that support. So it was really important to listen to the patient. There are, if your folks are interested, some YouTube videos that talk about, getting set up for Skype or adding that, some of those platforms to their computer or getting it ready. A lot of those are intended to engage the person on placing calls, and we're just asking them to connect to place a call. We've learned in our facility that it's important. Some of our locations within our facility don't have the audio video. Some people didn't have cameras. And as well, some of our providers are really hoping that we could get a tablet so that they could see the patient on the call and be looking at the tablet. Meanwhile, they're looking at the computerized medical record. So there's some considerations there. And then also room privacy. Just like always, we need to be at a location for our patients that's private. So the use of tech in our education tools, we can direct folks sometimes to, if we've got a facility web page, we talked about those industry partner resources. Those are some of the tech tools that a patient might be able to access. I've already mentioned, do we send a patient an email? Very sensitive to the cybersecurity rules, so we are looking at being able to send some things with a do not reply email. It's possible that we could also mail materials to our patients in advance or after. If it's appropriate to do it that way, we want to make sure that it's understood that the materials don't replace the DSMES. They're as an adjunct. So having them in advance is a really nice opportunity, especially I think if we're trying to engage in classes, having that toolkit ready for the patient. So in terms of how we've set up and tried to triage and assess for readiness, I think I've identified with my program kind of a three-tier that I look at is I want to engage with DSMES with my patients via telehealth, but based on some assessments, I'm just not able to do it because of perhaps tech support or inability to have a tech connection. So if I'm not able to do that, I'm looking at telephone check-ins. Maybe it's not DSMES. I might be doing something, maybe like an insulin adjustment that we sometimes do anyway, or we might be doing some other support about getting supplies, helping with some of the other needs that a patient might have. But it's also a really important thing we need to remember, telephone visits are not billable, so we best use those for support. But also with some of my folks I was trying to schedule last week, sometimes we're just doing a really important support check-in. We want to make sure we don't lose sight of these folks. We want to make sure we have a plan that we don't lose to follow up. And we want to make sure to get ourselves so that we're keeping folks engaged. It's really important that we don't lose that opportunity. And then sometimes in this time of COVID-19, I had an opportunity, I was connecting with a former telehealth patient in a rural facility about 200-300 miles away, making sure she had food security, making sure she was getting her med refills okay, making sure that there were folks there for support for her, and that's just kind of those kind of survival skills. So I think about setting up an individual appointment with telehealth as sort of a chart prep for appropriateness, a call to see if the patient's ready, and we would get a telephone and email contact. In our situation with Skype, we were going to obtain an appointment and advise the patient that not only will it be a telehealth visit, but there will be a charge, much like if they were in the clinic, and doing our due diligence of assessing needs, doing the DSMES visit, and then we have to make sure that when we document a telehealth visit that we say it is a telehealth visit via audio and video, and in our platform name I would insert Skype. So when I do my documentation, I'm going to document the outcomes just like I would always do, but include that the telehealth visit via audio and video Skype. And then I also have to document in my note that the patient consented to telehealth. The traditional model has ways of making that a lot easier if a patient's at a facility. It's just kind of one of those rules, but in this case, making sure that we're the people doing the documentation of the consent. So group visits, again, appropriateness, chart prep will help you know that, and engaging people in your contact for telephone could be that you're going to be doing the class and you're going to be sending an email out to all the participants, and they'll all join the class in a similar fashion like this presentation, but allowing for multiple invites. And so right now, I'm just setting up my one-on-one visits with my patients per Skype, but there's opportunity where I could invite multiple attendees. I haven't had that opportunity yet. I do teach some DPP classes to kind of it's two groups consecutively, two different rooms, so to speak. So I've got two different groups of individuals, however, different in that they come to a meeting room in a facility, but it kind of does create a little nimbleness, so to speak, to be able to kind of engage everybody and make sure you have opportunity to get people's involvement and input. So I see group visits as being trickier. I do not have a plan to do them right now, but I do think this is a great time for us to be considering, because we sort of are in a real live project going on right now of trying to do something and trying to see what our outcomes will be that best supports our patients. And again, distribution for materials depending on how your project is rolling out. And I think I heard this, we're really practicing within a research project from one of my peers here in Montana. I don't know if it was Lisa Rains or Deb Bjorsness who said we're really right now we're working in a research project. We're getting our data collection going just like we always do, but aren't we having an opportunity for collecting something else along the way? So just as though we're collecting our QI data, we're addressing where our clinical outcomes are, behavioral outcomes. We're doing that like we always do within our program guidelines for our patients, but we need to also be considerate of some of the things that we might not get tracked as reasonably. We might not have patients coming into our labs to get an A1C. So we might have a few limitations there in some of our data. We might be collecting new data sets. Like I mentioned, I kind of think of this in three phases, whether it's telehealth, a phone, or just some support. I want to collect some of my data that bases where the patients fall within that. I want to see where things are coming as far as how I do not want to lose people to follow-up. I do not want to lose their ability to control their diabetes as best they can. So in terms of tracking metrics, this would be, this is going to be individual to a program, and by no means a list that suggests I know something about this that's special. This is just me trying to think, what would I want to do in terms of tracking? In our situation at our facility, we've been directed to, when we document in our typical document structure for the DSMES visits, We can choose it's individual or initial or post-program, or we can choose other. So we're selecting the other box, something we never use, but it's going to also indicate for us to pull data based on this COVID-19 situation of telehealth in lieu of an in-person visit. So we also know that we could contact those patients who don't have Tech Connect and how we best used our telephone support. Maybe we find ways to connect to patients that we never thought about. One of my peers, I think it was Lisa Rain, says, a great way to do things is to survey our patients, find out what they want. Our patients can be the best teachers, can best educate us. And I think she said that really well because it reminds us they're going to tell us what they want. Like my little patient this morning, oh, Chris, can't we just talk on the phone like this? She wanted to minimize some of that issue. I don't know how group's going to go, I'll be honest. I think we're looking a lot of our outcomes right now individual, and I think it is good to do some sort of surveying for patient satisfaction and provider satisfaction. This could be pushing folks out of their comfort zone to some degree. I can speak to it and I'm happy and enthusiastic about it because I've been doing it for a long time, and I enjoy it a lot. It adds to my makes my population more robust, and I really do have a lot of fun. So for me, it's totally a win. So practice changes that are different for us, that time on triage. I've already looked at what my usual spend with a patient is going to be and added at least 15 minutes to think about per patient or more for getting triage to get something in place. Do we want to implement a survey tool? Do we want to implement something that gives us more information from our patients that could create a change to my program practice? And creating a plan for those patients who don't have telehealth potential access or don't want to do it, who tell us no, we're not interested in engaging in that way. And then my last statement on the survival skills. So I think that's really, really important to see where our patients are in our community right now. I think we are in one of those times when we tell people, what's your emergency preparedness plan? It could be that we're engaging some folks in this, and so we don't want to lose opportunities to support them. And the resource page from ADCES that supports all of the COVID-19 practices in place is available at this link. You'll be able to find a huge array of tools and information similar to what I presented today. I'm hoping with some of the resources that I gave to you, you're able to see exactly how you could find a platform, get started, but also really create that in-place vision of how your program goes live, how you still make that the same program for your patients over telehealth, and something important to always put at the forefront. Am I following my same education cycle? Am I assessing, planning for education needs that my patients telling me they want? And sometimes, as you know, we end up doing a lot of the support as well as the education in our care. So that brings me to the question slide. And I guess we can
have our ADCES Science and Practice staff on the call that can also help with some of the questions that were asked. But I'll kind of field them to Chris first. So Chris, the first question says, can I bill under the hospital's NPI number if I am providing telehealth from home during this emergency?
I'm going to refer that to the ADCES team. I do know that one of my providers here in our clinic is a primary care provider, and he is building telehealth from his home because of his age. We're not wanting him to come into the clinic. I don't know. Team, what does that answer to you?
So this is Leslie. Oh, I'm sorry, I got a little bounce back there. So this is Leslie Kolb, the Chief Science and Practice Officer at ADCES. And what I'd like to say is that we have not been given guidance on providing telehealth outside of the accredited program. So if you have an accredited site or you have an accredited program, you need to be there when providing the service. There has been no guidance on being able to provide the service outside of the primary site.
Okay, thank you, Leslie. The next question, it says, if you work in a clinic within a hospital that is in regulated space and has facility fees, are you still able to bill for telehealth? Do you have to perform it from within the hospital site?
I would say the same answer to that, yes.
Okay, great. Thank you, Leslie. Next question we have, is there a push to allow pharmacists to provide telehealth?
I know
There
the
is
answer.
a push.
Yes, yes. And
Yeah, go ahead.
Yeah. And I believe, and Leslie, you spoke to this, and maybe I should have not chimed in so readily, but we're all interested in that happening, and we're hopeful that CMS will provide us with something definitive on that. And Leslie, would you know if there's a timeline on that?
So we were going to bring that information to this call today, but unfortunately Medicare did not get back to us today. We were told that they had a conversation today on the DSMT benefit, and some of the things that we asked about were the pharmacists and the RNs being able to provide the service, as well as we asked Medicare about extending the lifetime benefit for this particular year, because in the case that we're utilizing telehealth now, we're actually kicking off and starting that timeline for being able to bill this benefit. So we are hopeful that we will hear something tomorrow, but more to come on that. As soon as we hear, all of you will hear, and we will post it in the COIs and have it on our website as well.
Wonderful, thank you. The next question we have, it says, is there a platform that is most conducive or appropriate to observe patients' techniques with diabetes devices? For example, blood glucose meters, pens, CGM, infusion set devices?
I think whatever you're going to do is going to be needing a camera to capture. I mean, you have to have a camera to capture. And if a patient was, for instance, using their smartphone, they just turned their camera around to place it so that they could show, kind of difficult, might need another person in the room, be able to show what they're doing to place an infusion site. But that's kind of what I've seen mostly, is that you're able to, kind of observe if they can flip the camera. I don't know that there's a platform necessarily. I do know that some of the EHR products, like the one we use, has access to like plug-in document stands and that type of thing, but those are traditionally within a healthcare facility. So I don't know that there's anything necessarily but if someone else on the team can speak to that, that'd be great.
No, I think the answer that you gave, Chris, is appropriate.
Okay, thank you both. Next question. It asks, okay, can we only see established patients, or can we also see new patients?
You can see new patients. Especially when we look at the MNT guidelines, it does indicate the coding for the first initial visit, and then it also gives a code for subsequent follow-up. So I think I've interpreted that to mean, yep, I can see a new patient.
And it's the same for DSMT. The waiver, the 1135 waiver, does include seeing new patients at this point.
Okay, wonderful, thank you. Next question. As an RN, can my RD be the rendering provider where I do telehealth and make claims with the RD as my rendering provider through Medicare?
The RD must be the educator, right? I mean, they must be doing the service, and RN cannot.
Yeah, you're absolutely right, Chris. So in a face-to-face program, yes, you could be the RN providing the service under the RD, but in the case of telehealth, an RN cannot provide the telehealth service at this time, which is one of the questions and one of the areas, like I mentioned, we are working with Medicare on.
Great, thank you. The next question. to kind of clarify what was said before, so you are not able to bill for DSMES if not done with audio and video?
Correct. Must be real-time audio-visual, cannot be billable just on a telephone or without the camera, without the audio, or excuse me, the video, pardon me.
Okay, great. I think that answers a lot of questions. Okay. The next question we have asks, is the POS code 02 built into the Epic system? And if you use a GT modifier, do you need to have a POS?
Leslie, are you on? That whole system is, I don't know about built into your EHR, and I'm just doing GT because my facility asked me to. I don't know if I felt like it was a requirement.
Yeah, that's a great question. We will be pulling all of these questions together and able to send them out to all the attendees once we have them answered. So I'm going to hold off on that one and make sure I have the exact answer for you. As far as Epic goes, I would definitely check with your billing department. They should know if that modifier is in there.
Great, thank you. The next question says, is a simple program considered appropriate? I have a service where I specialize in helping blind clients learn diabetes self-care skills. The screen component is not needed.
That doesn't meet CMS guidelines. I understand what they're saying if it's working with a blind population, and it does seem to speak to that. The program has to be, of course, recognized or accredited, but I would say your materials, to meet the guidelines would probably need to be in the patient's hands at the time. And I think that you have to meet CMS guidelines, and it's in your licensure to say you're doing it appropriately.
Okay, thank you. The next question, can you email patients home instruction about insulin or medication changes and just remove all PHI except for the name?
Oh, our facility doesn't allow us to do that type of education in terms of sending out things. Because of cybersecurity, we wouldn't want to really be sending emails. I wouldn't want to do much more than just an assessment form. Home instruction, I would think it would be safer, personally, if it were my decision to do, even if I couldn't do DSMES, I would do a telephone visit for that and have the patient verbalize back to me the understanding component.
Great, thank you. How do you capture consent? Do you send anything out for them consenting to the visit besides verbally?
We've been instructed that a verbal consent is appropriate, and we document it as such.
Great, thank you. Where can we find sample telehealth agreements and telehealth assessment forms assessing readiness for telehealth?
Leslie, would you know if that toolkit on the ADCES website has that?
I am not sure, but I definitely will look at that and get back to you all on that when we put out the questions. And we'll make sure that we provide links to it if it does.
Great, thank you. Next question. Will copays and deductibles for DSMES services be waived by CMS during this emergency?
Their language states that there still will be copays and deductibles. However, the provider of the service has the ability to reduce those or waive them. I've not gotten direction from my facility whether that's going to be happening, so I can't answer that we will do that, but the language states that they can be reduced or waived.
Okay, thank you.
The importance with that is that you're consistent. That is one thing that Medicare is very clear about, watching what a program does. So if you're going to waive it for one, you're going to have to waive it for all of your the people that you're working with. Consistency is important there.
Thank you. Okay, next we have reimbursement if for 1 hour individual and 9 hour groups. I've not been able to determine if this is still in effect. Do you have any insight?
Leslie, do you know that answer?
Yeah, that has not been waived yet. Right now it's still the 2 hours, up to 2 hours. Okay, so we all know in that first year it's 1 hour individual and 9 hours in the group. Telehealth can be provided in the group using some of these platforms that Chris reviewed with you. And it does make it a little bit more difficult, and there might be an uncomfortableness. This is something we're looking at right now to get more direction out to all of you. But I have not seen guidance where they have waived the 1 hour and the 9 hour at this point.
Thank you. Okay, next question we have, do the rules require the healthcare professional to be in the clinic?
I have not seen anything waiving that.
Right. When COVID-19 is over, will CMS discontinue this ability to bill for telehealth?
We don't know, do we?
Yeah, they've been pretty clear that this is a time period throughout the crisis that we're going through right now. We would wait at that point for more direction. I don't know exactly when it's going to end, but this 1135 waiver is specific to the situation. We would all love to be on the other end shortly, but I think the important thing to keep in mind is, for those of you who are able to do this and provide the telehealth, please start saving your data. If we're going to go to Medicare after the fact and say, look how great this worked, and look at our outcomes, and we're seeing improvements in some of this data, we need to have that to support it. So right now, I would go under the assumption that this is short term. And if that changes, then wonderful. But again, if you're documenting, as you should be as an accredited or recognized program, that information after the fact will be very helpful in advocacy things that we're doing.
Great, thank you, Leslie. Okay, here's a good question. What are the best ways for all of us to get these updates as they come out?
So if you go to our website, diabeteseducator.org, and you click on the coronavirus page, you'll see tons of resources in there, and there are links to all of these Medicare frequently asked questions on telehealth. The toolkit is in there, and the tips, and and everything that we talked about today is there, and we will be putting these slides up as well. I know that you have access to the PDFs. I saw a couple comments about the firewalls not allowing you to have them. We will make sure that you do get copies of the slides as well. But as for the links, please go to diabeteseducator.org, click on the coronavirus link, and you will get all of the information on the regulations, 1135 waivers, and so on.
Great, thank you, Leslie. Some people are asking, what are some other examples of teaching tools you use?
Well, I guess I spoke a little bit to some of the resources that I've used from industry partners outside of materials that when I'm working with patients, I'll say, okay, get the book with the lady with the rolling pin on it. Now we're going to go, I mark pages specifically that I want to make sure I get the patient to engage in so that it's, I kind of have a plan ahead of time what exact materials might. Given that their education plan is going to kind of predicate what exact materials I'm going to need and use. As far as insulin teaching, I use my big retinue of pens and toys for doing that, and I just make sure that my camera is able to, I kind of angle a little bit to capture, and I've even placed it a bit on my, I have a standing desk so I can stand it on my stand. Regarding glucometers, it kind of depends. The patient's going to be remote. They might be having something that's a different tool than I have, but I do the same type of teaching of, here's how most meters are done. Here's how, I've had a lady apply her freestyle sensor, those kind of things, and just try to put things in perspective of here's what it's going to be looking like, and showing her a few of my kind of office model tools. I don't know if that answers the question fully, but I don't deviate a great deal from what my usual tools are going to be. I just plan ahead more to find a location or a site in the materials that could help the patient get there quickly.
Great. Thank you, Chris. I would like to actually ask Kate Thomas, our Director of Advocacy, to speak about a bill that has been, there's a bill out there that actually speaks to a couple of the things that we haven't been able to talk to about today. And I know there were questions around FQHCs and rural health clinics. Kate, would you mind sharing with our audience a little bit of information about that bill?
Sure. Thanks, Leslie. As Leslie mentioned, I think we've all been anxiously looking at the U.S. Senate to see how they are going to proceed with passing the third coronavirus legislative package. This has been debated throughout the weekend, and we're hoping for a resolution soon, at least by the evening, although that's still pending. Included in that federal legislation would be a provision that would enhance Medicare telehealth services for FQHCs and RHCs during this emergency period. I think there was a recognition that some attention needs to be drawn to these specific entities, so this bill would expand that. So in terms of next steps, we would expect the Senate to pass this legislation, then it would have to go to the House to also pass. Once we have a final bill, it would be signed by the President, and then that would allow Medicare to begin the process of putting out guidance to FQHCs and RHCs in terms of how to proceed. So just because the legislation is passed, we still have to wait a little bit longer, much like we did on the Medicare telehealth side, to get some additional clarification. So we're just waiting for that first piece to get into motion.
Wonderful. Thank you, Kate. So we are actually going to wrap up this webinar. We have a lot of questions that we didn't get to, but as mentioned before, we are collecting all of them, and we'll be putting them, collecting them and answering them in some general FAQs. So I want to thank our team here and, of course, Chris for presenting today. This was excellent information. And we want to thank everyone for attending today's webinar, and again, apologize for any technical issues that happened. But we did record this webinar, and we are going to post it on our COVID-19 resource page by tomorrow, probably, or Thursday at the latest. The link to that page is in the webinar slides and also in the or on our website, diabeteseducator.org. And we will be having follow-up Q&A webinars on Friday, March 27th and Tuesday, March 31st, both at 2 p.m. Eastern Time. You can find information on both of those on our live webinars page under the education dropdown, and they're also linked out on the COVID-19 resource page that I mentioned earlier. We will leave the webinar room open for a bit, so you can go ahead and download those slides that you see on your screen. And again, we want to thank you all. This concludes today's presentation.